So this is the first video of respiratory system for medicine. So the detailed anatomy, relevant anatomy and physiology is discussed in the older videos. So for medicine, we will only remember the anatomy and physio parts that are clinically important and should be known as a doctor. So in anatomy, we will focus on these four things: osteology of thorax, intercostal space and its contents, pleura and lungs, mediastinal contents, and diaphragm. Okay, so in osteology, the first thing that should be known by a doctor is thoracic cavity is formed by what? It is formed by sternum, which has three parts: manubrium, body, and xiphoid, then clavicle, then vertebra, which are thoracic vertebra, because it is thoracic cavity, so T1 to T12, and ribs. So now types of ribs. Ribs are of three types: true ribs, false ribs, floating ribs. So true ribs are the ribs that attach. Okay, so all the ribs attach to vertebra. That is a definite thing. Then the ribs that, like this is vertebra, on the this part is a vertebra. So all the ribs are attached on left and right side to the vertebra. So ribs that come anteriorly and attach to manubrium are the true ribs. Okay. Then the false ribs that don't attach directly to the sternum but attach to each other's cartilage and as a common attachment attach to the xiphoid. And then the floating ribs that does not come anteriorly at all, just attach to vertebra in the midline and doesn't go anteriorly at all, are the floating ribs. So two ribs attach directly to sternum via its own costal cartilage, which are 1 to 7. Own costal cartilage attached to sternum directly. False rib attached to sternum, but its costal cartilage attached to costal cartilage of previous rib, 8th, 9th, 10th. So 8th costal cartilage attached to 7th, 9th costal cartilage attached to 8th, 10th costal cartilage attached with 9th. So these 8, 9, 10 are false ribs. Floating ribs that no attachment to sternum, they don't even come anteriorly, they are just like this, just attached to vertebra and midline and just floating ribs. Okay, then this is not to be remembered, just this is explained detail in the anatomy video, the old videos. For medicine, you just know that rib, what are the parts of rib. So it is a head, neck, and a costal groove. Okay, so what should you know is that in costal groove, the structures, the intercostal structure, which are arranged as vein, intercostal vein, intercostal artery, and intercostal nerve, like this. This is the rib, this is the costal groove. Okay, it is present on the inferior part, and the structure arrangements are like this vein. Okay, this is the thing that you should know. It's not a more important for medicine part. Okay, so we won't go into more anatomy than this. Okay, then important thing for anatomy that is relevant clinically also, like for x-rays and all these things, and even for surface anatomy things, which is events occurring at sternal angle. So sternal angle, also known as angle of Lewis, it is present at the T4 level. Okay, so sternal angle is where manubrium and the body of the sternum are joined, this part, and there is a ridge over here which can be felt here on examination, and the rib that attaches here is the second rib. Okay, so while locating, like while placing ECG leads or palpating, percussing in examination, what we do is we go from above. Okay, then we in the above the sternum, we palpate the fossa. Then after that there is manubrium. Then we feel this deep palpate this ridge. Okay, lateral to this ridge will be second rib. Below this will be second intercostal space. Then third rib, third intercostal space. This is how we locate ribs and intercostal spaces. So sternal angle is also known as angle of Lewis, present at level of T4. Okay, so what are the events? So costal cartilage, here is second costal cartilage and second rib. Mediastinum, junction of superior and inferior mediastinum. Okay, so above this is the T4 level, above this is superior mediastinum, below this is inferior mediastinum. Okay, and dermatome, it is not important. Dermatome, just remember dermatome as this. Dermatomes for sensor examination during anesthesia, or just thorax dermatomes are T2, T4, T6 and T10. T2 is above sternum, T4 at sternal level, T4 at nipple level, T6 is at xiphoid process level, then T10 is at umbilicus level. This is the dermatome of sensory supply. Okay, this is to be examined during anesthesia, that how much sensation is gone, or just remember this. Then arch of aorta, beginning and termination of arch of aorta is occurring at T4 level. Then SVC pierces fibrous pericardium coming from above. Then trachea bifurcates here. So this one is important. SVC piercing pericardium important. Arch of aorta begins and terminates at the level of T4, that is sternal angle, important. Mediastinum superior inferior division, important. Second rib and second costal cartilage attaches here, very very important. So let's concise this. This is our manubrium, this is our body sternum, this is our ridge that I talked about, the fusion of these two parts, there is a ridge there. This is also T4 level. Okay, this is our sternal angle. So at sternal angle, what is happening here is the SVC is piercing pericardium. Okay, arch of aorta is beginning and ending at this level. Trachea is bifurcating at this level. Okay, the rib attached is second rib. Vertebrae is at T4 level. So these are the things that you should know. Okay, this is the part of anatomy that was more important. Now come to less important part of anatomy. So in intercostal space and contents, you should know this. It is arranged as VN and the arranged as groove. Like this is the groove here. Structures are arranged when this much. Okay, then I don't think more than this is required for medicine. Then you should know muscles of inspiration. Okay, so main muscles of inspiration are ESCM and diaphragm. accessory are scalenes, SCM, serratus anterior, actus fini, pectoralis major and minor. Okay, muscles for expression. So expression is normally passive. Then accessory muscles are abdominal and intercostal muscles. So internal intercostal and innermost intercostal, these are the accessory. Abdominal are anterior abdominal wall muscles, which are transverse abdominis, rectus abdominis, external and internal obliques. Okay, so when it comes to intercostal arteries, it is not that much important for medicine part, but you should know this. Okay, so intercostal arteries are anterior and posterior. Posteriorly all arise from descending aorta, and then there was intercostal arteries. Okay, anteriorly intercostal जो arteries हैं, they are branch of brachiocephalic trunk. So brachiocephalic, this is aorta, arch of aorta, brachiocephalic trunk, then internal thoracic artery. Then internal thoracic artery gives anteriorly the intercostal arteries and posteriorly descending aorta. Then comes to intercostal veins. So this is also, this azygous system is also not that much clinically important for medicine, but it should be known. Okay, so intercostal veins. So anteriorly route is same, that is intercostal veins, which form the internal thoracic vein, which will be joining brachiocephalic trunk. Okay, then posteriorly there is a azygous and hemizygous system. Okay, so this is your superior vena cava. This is the right brachiocephalic vein, in which our this is left brachiocephalic vein. So our internal thoracic vein was also draining in this brachiocephalic trunk. This is the brachiocephalic trunk. Okay, brachiocephalic vein. Then posteriorly, first posterior intercostal vein drains directly to right. Second, third and fourth, they form right superior intercostal vein. Okay, so just remember this. 1, 2, 3, 4 intercostal veins on left side drains into the left brachiocephalic vein. Only first posterior intercostal vein drains into right brachiocephalic vein. Second, third, fourth drain the arch of azygos. So how is azygos formed? So 5 to 11 on the right side form azygos system, and then there are azygos. This is the azygos. Then there is accessory hemizygos and hemizygos. So hemizygous is on the left side 9, 10, 11 form hemizygous, and at the level of T8 they join to azygous. Accessory hemizygous is 5, 6, 7, 8 on the left side. At the level of T7 they join the azygous. Okay. So remember this. Superior vena cava. Okay. Here is left brachiocephalic, right brachiocephalic. So 1, 2, 3, 4 drain into the left brachiocephalic. 1 directly drains into left brachiocephalic. 2, 3 and 4 they drain into the arch of azygous. So how is azygous formed? All the remaining, that is 5, 6, 7, 8, 9, 10, 11 posterior intercostal vein on the right side. This is left side. Then 1, 2, 3, 4 directly drain into the left brachiocephalic vein. 5, 6, 7, 8 form the accessory hemizygous, which at the level of T7 joins the azygous. Then 9, 10, 11 form the hemiazygous, which at the level of T8 joins azygous system. So this is not that much important for medicine, but just to be known part of anatomy. Then comes the pleural tapping part. So we know this arrangement in the subcostal groove as vein. So the area of pleural tapping will be superior border of the inferior rib. Okay. So we do pleural tapping in the mid axillary line in the ICS 7, 8, 9 because their lung parenchyma has ended. This will be covered later. This is the just next discussion. So we were discussing about pleural tapping. So pleural tapping is done in mid axillary plane in ICS 7, 8 and 9. Okay, because their lung has ended. We will discuss later. This is done on the superior border of the inferior rib, whatever the space that we are doing it in. Okay, so what will puncture, this is discussed detailed in anatomy videos. So next come to pleura and lungs. So before this, just see this diagram. This is basic anatomy of diagram. This is T4 level, that is sternal angle. This is manubrium. This is body of sternum. This is xiphoid. Above sternal angle is superior mediastinum. This is inferior mediastinum. Then this is pericardial sac. Anterior to this is anterior mediastinum, posterior to this is posterior mediastinum, and this is middle mediastinum. Okay, now come to the pleura and lungs part. So pleura, is a serous membrane. Detailed of this is in the anatomy video, just know superficial for medicine. Pleura is visceral, which are tightly attached to the lung surface. Parietal is attached to the chest wall. Okay, and there is a space between them. That is pleural space. That is pleural fluid, which is around 100 to 120 ml. Then there are two recesses, costodiaphragmatic recess. Okay, and then there is one mediastinal recess. So this is the space between the lower border of the lung and parietal pleura. That is, this is visceral pleura. This one. This is lung visceral pleura. This is parietal pleura. So at two locations there is space between them. Okay, this is costodiaphragmatic. There is diaphragm. Then there are ribs here. So this is costodiaphragmatic recess. This is mediastinal recess on the left side. So on costodiaphragmatic recess is on the both sides. Mediastinal recess is on the left side because of the cardiac nerves there. Okay. Then extent of the lungs and pleura. This is important for medicine, clinically also. So we see this in three locations: mid-clavicular line, that is anteriorly, then mid-axillary line, that is laterally, then in the scapular line, mid-scapular line, that is posteriorly. So in mid-clavicular line, that is anteriorly, ribs are up to 6, pleura is, lungs are up to 6th rib, and this pleura is up to 8th. Okay, in mid axillary line, that is lateral, lungs are up to 8th rib, pleura is up to 10th rib. Posteriorly, that is in mid scapular line, lungs are up to 10th rib, pleura is up to 12th rib. So we can see here is at 6, 8 and 10, 8, 10, 12. Okay, this is for both sides of lungs. Then mediastinal relation, these are more detailed discussed in anatomy. Then about blood supply. So bronchopulmonary segments are physiological segment of the lungs. So they are surgical resectable segment. Separate, they have separate artery supply, venous supply, and separate bronchus. That is the tertiary bronchus supplying each. So trachea, primary bronchus is for both side lungs. Secondary bronchus is for each lobe, and tertiary bronchus is for each bronchopulmonary segment. So now artery supply of the bronchopulmonary segment. So this is the pulmonary artery, okay, which ends into bronchial artery. So bronchial artery is supplying oxygenated blood to the tissues of the or to the parenchyma of the lungs. Then there are pulmonary artery and vein. Okay, so bronchial artery is for oxygen supply to parenchyma of lung. Pulmonary artery is the artery that is receiving blood from right ventricle of the heart, that is receiving deoxygenated blood. So it is bringing blood to the lung parenchyma, but it is bringing deoxygenated blood, while bronchial artery is bringing oxygenated blood to survival of the parenchyma of the lung. So pulmonary artery is shown in blue because it is bringing deoxygenated blood for exchange and perfusion here. Then, so this is the bronchopulmonary segment. It has own tertiary bronchus. This is our alveolar sac. It has own bronchial artery. It has own pulmonary artery branch. But the pulmonary veins, they are not specific for each bronchus. They are present in the intersegmental septum. Okay. Now come to the bronchopulmonary segments. So there are total 20, 10 on each side. Okay. So this is our right lung. This is our upper lobe, middle lobe. This is our upper lobe, middle lobe, and lower lobe. So in upper lobe, apical, anterior and posterior. In middle lobe, just lateral and medial. And in lower lobe, all of them. That is apical, then there will be anterior, posterior, and lateral, medial. Okay. So this is discussed detail in anatomy. Just remember that bronchus are 10 on each lobe, and for medicine this is important. Which is dependent bronchopulmonary segment? So right lung, that is more dependent, that is more chance of aspiration and aspiration pneumonia. So right lung has more chances because right bronchus is more vertical. Right bronchus is more vertical and left bronchus is more horizontal. That is why right lung has more chances of aspiration pneumonia. And even that on right side, in standing position, posterior basal, obviously the lower lobe will be, so according to bronchus, the right lung is more dependent, and in that obviously the lower lobe will be going to be more dependent. Okay, so remember up to this, right lower lobe. Then in standing position, the posterior basal of the lower lobe is more dependent. In supine position, the apical of the, so this is the right lung, this is the right lobe. So in supine position, the apical bronchopulmonary segment of lower lobe is more dependent, and in standing position, the posterior basal is more dependent. Okay, then for medicine, yeah, esophagus, the esophageal varices branches are important, which are venous by left gastric vein, and this is portal system supply is left gastric vein. Caval system supply is azygous. Okay, so these are following portocaval anastomosis, which may end in esophageal varices due to portal hypertension. So again, portal supply is left gastric vein, and portal branch is left gastric vein, and caval branch is azygous vein. Okay, then comes to thoracic duct. So thoracic duct is not that important in medicine, but it is a big part. So just have an intro here. So it is largest lymphatic vessel of body. It has beaded appearance due to presence of numerous walls. So it drains all except right side. So it is drain except right head and neck, right thoracic wall, right upper limb, right surface of the heart. Okay, and then superior surface of liver. This is the area that it is not draining, except that it drains everything. So it's the how its route. So it get drainage from both left and right lower limb, and there is a dilated sac formed in the abdominal area at the level of L1, which is called cisterna chyli. Then it ascends upwards, and at the level of T12 it enters thorax via orifice in the diagram. Okay, then it deviates at the level of sternal angle and deviates from right side to left side. Okay, so you can remember this, that it is deviating from right to left, so it has now come to left side. Okay, at sternal angle, so it is draining the left part and not draining the right side. Then at the level of C1 it drains into the venous system at the angle between left subclavian and left jugular vein. So this is the thoracic duct. Then about diagram, just you need to know that there are three orifices in diagram: orifice for inferior vena cava, for esophagus, and for aorta. That much is enough. So the anatomy part is done, which is relevant.